Muscular dystrophy refers to a collection of disorders characterized by the gradual weakening and deterioration of muscle tissue. I begin with Duchenne's muscular dystrophy or pseudo-hypertrophic muscular dystrophy. Each muscle fiber is enclosed by a cell membrane called the sarcolemma. The protein dystrophin is essential for the mechanical strength and stability of the sarcolemma. A lack of dystrophin is associated with Duchenne muscular dystrophy. Collagen and adipose tissue are deposited in the muscle, resulting in pseudohypertrophy of the calf muscles. Impairments of Duchenne's muscular dystrophy. 1. Progressive muscle weakness occurs from proximal to distal regions, starting around 3 years of age with initial difficulties in walking and leading to death in late adolescence or early adulthood. By 3 to 6 years of age, they often display a waddling gait and struggle with activities such as running, jumping, and climbing stairs. 2. A positive Gowers sign, which is manifested as patients using their hands to walk up from the thighs. It happens due to weak quadriceps and gluteal muscles. Lumbar lordosis and calf hypertrophy are common features, with the calf muscles having a distinct rubbery texture. 3. Contractures and deformities develop because of muscle imbalances, particularly in the heel cords and tensor fascia lata, along with lumbar lordosis and kyphoscoliosis. 4. Developmental milestones may be delayed. 5. The ability to ambulate will eventually be lost, necessitating the use of a wheelchair. 6. Progressive cardiopulmonary limitations occur over time. Examination in muscular dystrophy. 1. Muscle strength is assessed using manual muscle testing and a dynamometer. 2. Both active and passive range of motion are evaluated. 3. Functional testing is conducted. 4. Skeletal alignment is checked for lordosis, scoliosis, and kyphosis. 5. Respiratory function is assessed through chest excursion during breathing or the use of a spirometer. 6. The need for adaptive equipment is evaluated. Goals and prognosis of physiotherapy interventions. 1. The goal is to maintain mobility for as long as possible by encouraging recreational and functional activities to preserve strength and cardiopulmonary function. 2. Joint range of motion is maintained through active and passive range of motion exercises, as well as positioning devices like prone standers or standing frames. The gastrocnemius and tensor fascia lata are typically the first muscles to shorten. Night splints may be utilized. 3. Electrical stimulation of muscles in younger children has shown a potential to improve contractile ability. 4. Parents and family members are educated and supported sensitively. 5. Avoid exercising at maximal levels, as this may cause injury to muscle tissue. 6. The use of adaptive equipment is supervised as needed. 7. The disease is progressive, leading to respiratory insufficiency and death in young adulthood. 8. Palliative and supportive medical management. 9. Steroids like prednisone are used to increase life expectancy by reducing pulmonary dysfunction. Antibiotics are prescribed for pulmonary infections. 10. Orthopedic surgery may be performed for scoliosis or muscle lengthening of the gastrocnemius. Becker muscular dystrophy. The pattern of muscle weakness is from proximal to distal regions similar to the one of Duchenne's muscular dystrophy. The pelvic and thigh muscles are typically the first to be involved, although calf hypertrophy is also observed. There is less pronounced weakness of the tibialis anterior and peroneal muscles compared to Duchenne's muscular dystrophy. Neck flexor strength is relatively preserved, and contractures, scoliosis, cardiac dysfunction, and cognitive impairment are less common. Cardiac issues may arise before skeletal muscle weakness becomes apparent. Patients with Duchenne's muscular dystrophy often survive into adulthood and remain ambulatory beyond the age of 16. Death usually occurs between the ages of 30 and 60, primarily due to cardiomyopathy or respiratory insufficiency. Emery-Dreifuss muscular dystrophy. There are three primary clinical features. 1. Muscle weakness. Muscle wasting is often most severe in a humeroperoneal distribution. Some patients exhibit hypertrophy of the extensor digitorum brevis muscle alongside significant posterior leg wasting. Selective weakness of elbow flexion and finger extension may occur. Muscle wasting is particularly noticeable in the posterior compartment of the leg, and contractures of the quadratus lumborum in the lower back can result in a rigid spine. 2. Contractures. In adults, flexion contractures of the wrists, elbows, ankles, and neck are common. 3. Cardiac involvement, which can lead to sudden death. Cardiac involvement typically emerges between the second and fourth decades. Facioscapulohumeral muscular dystrophy. The disease typically becomes clinically apparent in the second decade of life, although up to 30% of patients may remain asymptomatic. The usual pattern of weakness involves simultaneous scapular fixator and facial muscle weakness. Patients may be unable to whistle, sip through a straw, or blow out their cheeks. They often sleep with their eyes slightly open. Weakness follows a descending rostral caudal pattern, affecting the face, shoulder girdle, peroneal muscles, and hip girdle. Patients exhibit wide palpebral fissures, reduced facial expression, and a transverse smile. Neck flexor muscles are relatively spared compared to extensors. The shoulders appear forward sloped and rounded, with pectoral atrophy and prominent axillary creases. The scapulae are winged and laterally displaced, with preferential wasting of the lower trapezius muscles. The biceps and triceps are disproportionately wasted compared to the deltoids, creating a Popeye appearance. There is also a preferential weakness of the lower abdominal muscles, causing the umbilicus to move upward during neck flexion, Beavor's sign, a finding specific to FSHD among muscle diseases. Foot dorsiflexion is affected while the gastrocnemius is spared. Reflexes are diminished. Associated features include hearing loss and retinal telangiectasia. Approximately 5% of patients experience cardiac involvement, primarily manifesting as supraventricular tachyarrhythmias.